Are you afraid of endoscopy? Are you afraid of colonoscopy? Have you heard of ERCP? Hello friends, this is Dr. ARGHYA BASU, gastro and cancer surgeon, welcoming you all to one of the most interesting episodes in our healthy chit chat on endoscopy, colonoscopy and ERCP. Hello friends, this is Dr. ARGHYA BASU, gastro and cancer surgeon, welcoming you all to a very interesting episode of your own YouTube channel ARGHYA, where we discuss various gastro, cancer and surgery related problems and try to help our patients and viewers with accurate and state-of-the-art medical guidance even at personal level. In my practice as a gastro and cancer surgeon, in my day-to-day life, I get huge number of patients who are suffering from GI disorders. And to diagnose a GI disorder, the most important tools that I have in my array is endoscopy and colonoscopy, other than USG, CT scan, MRI, वगैरह वगैरह. Now USG is considered a routine bedside test. Nobody considers USG as a special test nowadays. CCT or contrast enhanced CT scan and MRI are considered as imagings. Now make one thing very clear that all these imagings are just taking photographs of your body, your tummy or your chest from external point. They are external cameras. They are taking views of your body from outside of your body, and all of them are mostly two-dimensional, except a few three-dimensional images like reconstructive images of CT scan or MRI. The only invasive test in gastroenterological aspect that we have are scopies. Now what are scopies? From where does this word scopy come? It comes from scope or telescope. Telescope or scope is actually a camera which is mounted in the front of a pipe. The pipe is inserted through your any orifice in your body, like your mouth, like your anus or rectum, like your nasal opening, like your ear. We can put in pipes through all the orifices that our body actually has. So these are all kind of scopies. The scopies do not end with endoscopy and colonoscopy, but actually these scopies can be of numerous type. Whenever we are putting the pipe inside our bronchus or respiratory tree, it is called bronchoscopy. Whenever we are putting the pipe with the camera inside the nose, it is known as nasal endoscopy, lichen, so on and so forth. So there are n number of scopies that are possible, but here we will limit our discussion on gastrointestinal scopies, which are actually endoscopy and colonoscopy, and ERCP is a special type of scopy which is utilized for some special purposes. We will talk about that later on. Now what are endoscopies and colonoscopies? Basically endoscope and colonoscope are a special kind of tubes that has special type of cameras mounted on the front of that pipe. That pipe is inserted inside the mouth or anus. Now, whenever I prescribe endoscopy or colonoscopy to a patient, 90% of my patients say, ডাক্তার বাবু মুখের মধ্যে দিয়ে পাইপ ঢোকাবে, এত যন্ত্রণা নিতে পারবো না, অন্য কিছু বলুন. But it is not possible, my dear, to see the inside of your stomach or the colon. I need a three-dimensional real-time image that can be availed only by sending that pipe through your mouth or through your anus into the exact location of the pathology. But don't be afraid, these are all myths. In previous times like 20, 30, 40 years back, when we used to have very thick type of endoscopes and colonoscopes, and they were rigid scopes. Rigid scope means it is just like a bamboo stick. It is not curved, it is not malleable, it cannot take the shape of the intestine, and we used to put in that rigid sigmoidoscope, rigid colonoscope, rigid endoscope, rigid esophagoscope inside mouth or anus. But nowadays, as our medical science had advanced, we have most advanced kind of scopes. All these scopes, be it endoscope, be it colonoscope or any other kind of scope, all these have very narrow gauge. They are very thin pipes, thin tubes, and they have high definition cameras mounted in front of them. and whenever we pass those very thin tubes inside your mouth or inside your anus, you do not feel pain at all. So don't be afraid at all. These are not painful procedures. In most of the cases, we use local anesthesia in the form of xylocaine spray or xylocaine liquids just to desensitize the oral cavity or the anus, so that whenever we are putting in the scope for the first time, it doesn't pain at all. In almost all good centers, we use local anesthesia before putting in these tubes. Added to that, in some patients who are very anxious, who are very much apprehensive, and who doesn't let anyone put any tube inside his or her mouth or anus, we might use little bit of anesthesia. That is not truly anesthesia, it is called sedation. मतलब पेशेंट को थोड़ा सा 5 मिनट 10 मिनट के लिए सुला के हम लोग वो स्कोपी करते हैं. सो इट इज नॉट एट ऑल ए ट्रॉमेटिक प्रोसीड्यूर, इट इज नॉट एट ऑल ए पेनफुल मेमोरी, इट इज नथिंग. It's just a day-to-day routine scopy. So whenever we are doing endoscopy and colonoscopy, we make sure that the patient doesn't have a traumatic experience. So it is our duty to give you a pleasant and very pleasant memory of the entire procedure so that it doesn't traumatize you. Now, what purposes do we use endoscopy and colonoscopy for? Endoscopy is basically used to view your mouth or oral cavity, then esophagus or food pipe, then inside of your stomach, and we can reach with an endoscope through initial part of your small intestine like the duodenum. This is the limit of normal endoscope. With a colonoscope, we introduce the colonoscope through the rectum or anus, and then we visualize the entire rectum, sigmoid colon, descending colon, transverse colon, ascending colon, and up to ileocecal junction. That is the junction of small intestine and large intestine. And this entire route can be seen in a 3-dimensional real-time image, so that we can get hold of the exact pathology lying in upper GI tract or lower GI tract, and we can treat the patient accordingly. Now you will tell me, what is the point of taking photos only if you cannot do anything? Who has said that it is endoscopy or colonoscopy is done only for taking images? Not at all. It is a diagnostic as well a therapeutic procedure. What does therapeutic means? Therapeutic means whenever we are doing the procedure, at the same time we are doing some interventional procedures along with it. Like with endoscopy, upper GI endoscopy, we can take rapid urease test samples for Helicobacter pylori infection to see whether the patient is having H. pylori induced gastritis or not. If we can get RUT positive, we will be giving anti-H. pylori treatment with that. As simple as that. Next, we can take multiple biopsies if we are suspecting a growth, a cancer, a tumor, or any other kind of swellings or ulcers in stomach or in esophagus or food pipe, inside oral cavity, inside duodenum or small intestine. We can easily take biopsies from multiple sites of that ulcer or that wound, so that we can get to know whether it is malignancy or cancer, whether it is tuberculosis, whether it is any other kind of infection or not, and give the patient treatment accordingly. Other than these, we can do some other procedures also. Like in case of cirrhosis of liver patients, we have large columns of veins filled with blood, which actually bursts, and patient gets recurrent hemoptysis or blood coming out with cough or hematemesis, bleeding spontaneously through mouth. This happens when the patient is having severe portal hypertension and the veins are bursting inside the patient's tummy or the patient's food pipe. So we can put the patient under endoscopy and do EVL or endoscopic variceal ligation of or banding. It is commonly known as banding of these engorged venous masses, through which we can control the bleeding in an acute as well as chronic settings. Now this is about endoscopy. Similarly, during colonoscopy, what we can do? By colonoscopy, we can take multiple biopsies. First of all, we can see whether the entire GI tract is patent or not, whether it is passable, patient is passing stool normally or not. Then, if we can see any ulcer, any growth, any tumor, any malignancy suspected in the entire colon or ileocecal region, we can take multiple biopsies from that lesion. Again, do we have only cancers in small intestine or large intestine? Not at all. There are a number of other gastroenterological diseases like irritable bowel syndrome, like inflammatory bowel disease, which involves Crohn's disease, ulcerative colitis, and a number of other types of colitis also. In these colitis patients, we get non-specific or specific kind of ulcers in the entire GI tract. Crohn's disease is such a disease which can affect any area of the GI tract starting from mouth to anus. Whereas in case of ulcerative colitis, the disease is mostly limited within the colon, but it can occur to any part of the intestine as well. Whenever we are getting that kind of disease pathology, we are suspecting Crohn's disease or ulcerative colitis, we can take multiple biopsies. And if the biopsy is positive for ulcerative colitis or Crohn's disease, we can institute specific treatment for that specific disease entity. So that Scopes doesn't only give us a three-dimensional view, but as a therapeutic procedure, it helps us to come to point our diagnosis and institute exact treatment. So Scopes are inevitable when we are dealing with a gastrointestinal disease. Now I will come to the last part of these gastrointestinal Scopes immediately. Please listen to the video till the very end so that you don't miss any vital point, and at last where I will share with you the links how you can get in touch with me and get personalized advice and guidance. Now we will go to the treatment and further discussions part, but before that, if you are enjoying the show and अगर आपको कोई benefit मिल रहा है तो please ये चैनल को सब्सक्राइब कर लीजिए and बेल आइकॉन को प्रेस कर दीजिए so that you will get notification every time we post a video, and this will give me and my team a huge inspiration for our hard work. Thank you. Now without any further delay, let's dive deep into the problem and how we are going to tackle it. Now I will discuss with the most challenging type of scopy in endoscopy section. It is done usually through endoscopy, not colonoscopy, because it is here we are dealing with the second part of duodenum. Now all of us knows that the common bile duct and pancreatic duct opens in the second part of duodenum through a ampulla, which is known as ampulla of water. So the patient often comes to us with obstruction in the entire hepatobiliary system leading to jaundice. This obstruction can be due to stones, can be due to worms, can be due to malignancy, can be due to tuberculosis, can be due to idiopathic strictures, can be due to injury during cholecystectomy or gallbladder surgery. There are n number of causes why the patient can have a jaundice, specifically obstructive jaundice. This is called obstructive or surgical kind of jaundice. Now when a disease is named as surgical, it has to be treated surgically or at least through some intervention. ERCP is that intervention. What is the full form of ERCP? Endoscopic retrograde cholangiopancreatography. Now this is purely technical. I am not going into technicalities. I will tell you about the nitty-gritties in layman's terms. Here the patient is having obstructive jaundice due to some kind of obstruction in the hepatobiliary tree. That is mostly in the common bile duct or hepatic duct. So what we will do? For this kind of procedure, we need a special kind of endoscope which is known as side viewing endoscope. In a side viewing endoscope, you can see in a normal endoscope, the camera is mounted in the front of the tube. So whenever we are passing the tube, we can just see the surroundings from a 0-degree point of view. But for ERCP, you need a side viewing scope. That, suppose this is the scope, the camera is mounted on the side of the pipe, so that I can see the entire side lumen, not only the front side of my gut lumen, but also the sides. Here I am seeing the front as well as the sides. Why do I need that? Because the ampulla of water is located in the wall of the small intestine. So here, to penetrate through that ampulla, I need a side view. So only my front eyes are not sufficient. I need eyes towards my side also. So here what we will do, we will, through that side viewing scope, we will see the ampulla of water. Then we will put one wire through that ampulla of water, and we will pass. Then we will do one sphincterotomy, or we will make the mouth of the ampulla bigger. Sometimes small stones in CBD can pass spontaneously through this sphincterotomy also. However, we always put in a stent or a plastic or metallic tube, so that the bile and redundant stones or collected pus can easily come through that stent. Now, in case of ERCP, we can do it with metallic stent, with plastic stent. When do we use plastic stents? The plastic stents are usually used when we are using it for a short time purpose, like CBD stone or worms or other kind of infections where we are suspecting a shorter hospital stay or shorter length of duration of the disease. Here we place the plastic stent in the CBD or common bile duct, and we remove it after around 4 to 6 weeks, so that the disease is completely cured within the 6 weeks, and then removal of the stent won't cause any further obstruction or jaundice to the patient. This is a temporary procedure. Now the other thing is metallic stent. What is a metallic stent? Metallic stent is a pipe again, but that is made up of metal. So when do we put in a metallic stent? Putting a metallic stent is a permanent procedure, and this is a non-reversible phenomena. Why non-reversible? Because the metallic stent gets ingrained inside the wall of the common bile duct, and it becomes a part and parcel of the CBD wall, so that it cannot be removed from the CBD for the rest of the life of the patient. So naturally, when we will do that? We will do that only in case of terminally ill patients, terminally ill cancer patients, where we are expecting that the patient is not going to survive for more than 3 months, 6 months, or one year whatsoever, so that we won't need to remove that stent again. In that case, we will be using metallic stents, because plastic stents have narrow caliber, they are narrow tubes. Once the cancer or the tumor grows, it engulfs the stent. But when we are using metallic stent, it is made of metal, it is hard, so the cancer or tumor, it won't be easy for the cancer or the tumor to engulf the stent or to block that lumen, so that until the patient is living, he or she is not expected to have jaundice further. This is the sole purpose of doing stenting, is to drain the bilirubin and to drain the jaundice, and after treating the patient from jaundice, then we start actual other treatments. Because once the patient is having jaundice, you cannot give chemotherapy, you cannot give radiotherapy, you cannot give any other kind of treatment for cancers unless and until the jaundice is relieved totally. You can get connected with me and follow my posts, videos and blogs in my social handles given in the description box just below. If you want a personal consultation with me, please WhatsApp or call in the following numbers. My team members will personally get in touch with you as soon as possible. Whatever questions you have in your mind, please mention them in the comments section. So this is your friend Dr. ARGHYA BASU, gastro and cancer surgeon, signing off for today. We will be meeting very soon in our next another episode with an more interesting video. Till then, take care, bye bye and Jai Hind.